Hi, okay, so this is your Unit 11 recap over the musculoskeletal system. And so we're going to start off going over the osteoarthritis, which as you know is a degenerative joint disease where cartilage in the joints will deteriorate over time and the smooth surface becomes rough, causing irritation, therefore leading, it's the damage and pain. What are the risk factors for osteoarthritis? Well, obesity is a major factor, all right, risk factor. So obesity, joint stress, strain over time, a joint injury could be heredity, and of course age. As we get older, the more wear and tear on our joints, we're going to have some osteoarthritis. So then what does it look like? Well, pain is the operational word, right? The pain will get worse with activity. So with rest, it is relieved. And then if you start exercising or walking, that will make it worse. Other things that will make it worse will be humidity, increase in humidity. So that will increase the pain. The joints may be swollen. You could actually see the swelling. They may be reddened, or the person may just be complaining of pain. There may be a grating sound of the joint with movement. The individual would have a limited range of motion, and then there's muscle weakness around the joint. And it gets worse because the muscles get weaker, and so we have less joint support. So how do we treat it? Medications is the way to go initially, and we start off with the Tylenol. Moving on, this is the protocol. This is the course that doctors follow. After Tylenol, then we move on to the NSAIDs. Now, they're not just, the small doses that we're used to taking. If it's Tylenol, they take a gram at a time. If it's the NSAIDs they are on, then they take 800 milligrams every 8 hours. So it's massive doses of the medications. Once the NSAIDs are not effective in managing the pain, then they move on to the COX-2 inhibitors. And of course, we know that as we move up the line, then we are increasing the possibility of those side effects, those cardiovascular side effects that come with the COX-2 inhibitors. Other medications would be corticosteroids. They may actually give oral corticosteroids or actually inject them into the joint. Glucomycin chondroitin is another one, but as I said, people are very impatient. That takes months for it to be effective, if it's going to be effective, and it's a problem with diabetics. There may be injection of artificial joint fluid. And then, of course, the big one would be the weight loss. The person may be referred to PT either for strengthening exercises and, of course, to investigate or look at other alternative treatments such as application of heat, ice rubs, TENS, those types of things. Now, the other thing that and how we treat it, of course, would be our teaching for the patients how to go ahead and manage it. And one of the things that we do want to touch on is joint protection. And like I say, if you look on page 332, that chart 20-6 will goes over ways to protect joints. And so it's simple things, instead of carrying your handbag by, with your hands, the finger joints, the hand joints, wrist joints, for us to carry it over the shoulder. So we use a larger joint. For us to use assistive devices as needed. Use two hands instead of one. Don't push with your fingers when getting up from the chair or the bed, but push with your palms and use both hands. Do not bend at the waist to reach. Bend at your knees and keep your back straight. So those are just some of the techniques as to how to protect the joints, and we need to teach them so that they will be as mobile as possible because it is painful for them. And we want to decrease the strain and the stress on the joints. All right, surgery. If it gets to a certain point where there's complete, the cartilage is gone. All right, so we have bone grating against bone, or the pain is just too severe, or the functions of the individual, the mobility is just too limited, then surgery is considered, and we're just going to cover, any joint can be operated on, but we're going to look at the hip and knee surgeries because those are major type surgeries. So joint replacement for the hip, one thing to keep in mind is that there is tremendous blood loss with a hip surgery. And so hydration is very important, and monitoring for any kind of bleeding from the site. All right, so with any of your hip joint surgeries, you're going to monitor for any kinds of complications. And especially, like I said, I'm really addressing knee and hip. Monitor for DVT, and we know what to do. We covered in our Unit 9 the actions to take to prevent a DVT, and so that would be early ambulation. It's a little bit more difficult with this type of surgeries because we know that they're going to be immobilized for a greater or a longer period of time. But it's important for them to get a low molecular heparin, and also the use of sequential compression devices. All right, we're going to monitor the site for any type of infection. Keep in mind, and a lot of times the patients that we see for hip replacements are your elderly patients. Keep in mind that with the elderly, the only sign or symptom of an infection may be confusion, okay, a new onset of confusion, and not necessarily what we expect to see with an infection, the tachycardia, tachypnea, elevated temperature, and things like that, okay, so confusion. We're going to go ahead and employ pain management. All of these patients, it is quite painful for them to not only the the surgery, but the recuperative period. They are going to be on opiates. Morphine is the drug of choice, and it will be delivered by PC pump. On rare instances, it is delivered, and then we can give fentanyl also. It is delivered by epidural pumps. Okay. We want to, with a hip, make sure that we take care of the extremity, that we position the patient using an abduction immobilizer at all times, and that means turning the patient. We turn the patient with that wedge in place, and that's to prevent any hip dislocation. A sign symptom of hip dislocation would be pain and shortening of the leg. We're going to teach them how to get around, it's a weight-bearing training so that they do not put that excess weight on that affected extremity, that they use their unaffected side to lead with, to pivot with, and that they use assistive devices as needed to prevent any kind of joint injury. With a knee, of course, they're going to be on their CPM, their continuous passive range of motion machine. And so, our focus with them is to maintain range of motion. Bottom line is that we want them to ambulate as soon as possible. Okay, the next section here is the rheumatoid arthritis, which is an autoimmune disease that attacks the joints and other organs. So it's a systemic type disease. What happens with the joints is that the cartilage becomes inflamed. That's what happens with RA. It's flare-ups or an immune disorder, an autoimmune disorder causes inflammation. So this inflamed cartilage, of course, then will cause joint pain. It affects women more than men. And the one thing with rheumatoid arthritis is that the joints, bilateral joints, are affected. Different from osteoarthritis, which may be just, my left hip is, has arthritis, but my right hip is okay. Here, if I had problems with my left hip, I would have those same problems with my right hip. It is bilateral joints. And so what does it look like? Well, the joints may appear swollen, painful, they look inflamed, and then we have deformities. The deformities usually involve the hands and feet, all right? So we have to, and that's what it ends up, the end result of rheumatoid arthritis will be the deformities. So we're looking at a lot of PT with these individuals, using devices to reduce what we call deformity prevention devices to, prevent deformities from happening, because like I said, it's the hands and the feet. So I would have deformities in both my hands, so that really impacts the use of my hands. And if I have them in my feet, then it impacts, I may not be able to walk, so I may be ending up in a wheelchair because of the rheumatoid arthritis. So one of the characteristics of the pain is that when they get up in the morning, when they awaken with a joint pain and stiffness. And this usually is relieved after 1 hour of activity, getting up, moving around. After about an hour, that joint pain and stiffness is released. They will also have limited range of motion, of course, because of the joint pain and the muscle weakness that occurs with those muscles surrounding the joints. The other thing, remember, it's systemic. So they do have eye problems. As Jordan's syndrome, which is a decreased tearing that occurs and decreased salivation. And they need to, of course, they are at risk because of the inflamed eyes. They are at risk for eye infections, and it's very important that we teach them about instilling their eye drops. Other signs and symptoms would be fatigue, weakness, difficulty sleeping. They'll have fevers, and the severity comes and goes. How is it treated? Again, NSAIDs, anti-inflammatories, right? The NSAIDs, the COX-2 inhibitors. With them, instead of application of heat and cold, like with the osteoarthritis, warm compresses help. So that means the application of warm, moist compresses is what's going to help. Physical therapy, of course, will be a big component of their treatment, and then those deformity preventing devices. Medications are very potent. Besides the NSAIDs and the COX-2 inhibitors, we're talking about the anti-rheumatic drugs such as methotrexate, which we know is a poison. It's a chemo drug. Enbrel is another one, Humira being another one. Okay, osteoporosis is the next one on here, which is the generalized progressive reduction of bone density. We're losing our bone density. This results in weakness of your weakness of the joint and skeletal strength. All right. So with this weakness, what's happening with the bone? If you just think it's becoming like a dry sponge, if you bend it, it breaks. That's what's going to happen with a bone. And little movements such as I twisted my ankle, instead of having a little sprain, I'm going to have a fractured ankle. I cough and I cough, I don't even have to cough vigorously or forcefully, and I end up with some fractured ribs. I slip from the chair to the floor. I miss the chair and I end up on the floor and I end up with a broken hip. So what occurs is what we call spontaneous fractures, and that's usually when it's diagnosed, when the individual goes in for a fracture and we discover that really the person has osteoporosis. What are the risk factors for osteoporosis? Here, a small frame, small stature, a slender individual is at risk for osteoporosis. Females, it occurs more frequently in females, postmenopausal females especially, Caucasian, people who like to drink, and I'm not talking about just, 4 ounces of wine a day or something like that, but people who do like to drink alcohol, smokers, and of course steroid use. What does it look like besides the spontaneous fractures? What we're going to see, the typical picture of osteoporosis is that hunchback little old lady walking with a cane. And so they can have decreased height, and they may lose up to 6 inches. Those spontaneous fractures, they may have that low back and neck pain. Compression fractures are common. Hip fractures are also common for them. They'll have weakness, they'll be unsteady, so that's what the person will look like, or what osteoporosis looks like. How do we treat it? Of course, calcium supplements. And anytime that we give calcium, we need to give vitamin D. We have the biphosphonates nowadays, and so if they are receiving a biphosphonate, we need to teach them about it. There are different ones, right? So for example, with the Boniva, that's oral and it's taken once a month. Fosamax, also oral, but it comes in different dosaging. It can be weekly or it can be monthly. So we do need to teach individuals how often to take this medication. And if it's a monthly basis, it's like to take it on the 30th of every month. They need to be consistent. and have it scheduled just right. So the other thing that we teach them about taking, for example, the Boniva is, or a biphosphonate, right, would be take it with a full glass of water, take it upon rising in the morning on an empty stomach. Do not drink or eat anything else for at least 30 minutes, preferably 60 minutes. If you need to drink something, you can drink clear water, but nothing else. Remain upright for at least 30 to 60 minutes. Now, exercise is part of the treatment with osteoporosis, muscle strengthening, the weight bearing exercises. And so, we want to incorporate an exercise program into the treatment. And this is when we tell them while they're waiting, they have to remain upright for those 30 minutes or so. This is the perfect time for them to do a morning walk. And then the other thing with the biphosphonates is we need to teach them to protect themselves from the sun. It is photosensitive. The next section here is the herniated disc. What happens with the herniated disc is that the small portion of the disc pushes out through a tear in the vertebral column, right? Pushes out through that tear, irritating a nerve. So depending on where this bulging occurs, those are the symptoms that we're going to have. Normally, or not normally, commonly, they occur in the lumbar region. But you could also have bulging discs in the cervical region, okay? So what does it look like? Back pain. Lumbar region being the most common area, so a lot of people, this is the chronic low back pain that they suffer. It could also, like I said, be cervical, but if it is cervical disc herniation, their back pain is going to be worse at night when they're lying down, and it'll worsen with coughing, sneezing, and laughing. The low back pain, the lumbar pain, actually increases with activity or prolonged standing or prolonged sitting. So it's throughout the day. They also, along with the pain, the back pain, may have some sort of nerve irritation. So the extremity, depending where it is, if it's cervical, they may have a little bit of numbness, tingling, weakness of the upper arm. It's going to be one side only. If it's lumbar, then it's the sciatica that will be involved. So they'll have that sciatica or sciatic nerve. They'll have sciatica, and it can go all the way down to the heel, or just part of it down to the thigh, or just the buttocks. But they'll have that tingling, pain, numbness, weakness, and sometimes even paralysis. All right, so how is it treated? Well, we look at modifying their activity, right? So we're going to teach them about avoiding bending, lifting, and to avoid those, not to reach over their shoulders, to avoid prolonged sitting and standing. One of the things is we teach them about positions that will relieve their back pain, such as lying down on a flat surface and propping their legs up. Usually we teach them lie down on the floor, put your legs up over the couch or a chair, and keep this position for about 15 minutes. This reduces the pressure, the pull on the back, and there's some pain relief that occurs. Other things is that they find relief by sitting in a reclining chair. So reclining chairs are a good thing for them. They will have PT, and PT can do core strengthening exercises with them, the lap band exercises. They can do ice rubs. They can do application of TENS. So PT would be part of it, part of the treatment. Medications, NSAIDs would be one of the types of medications to be given. Again, usually it's ibuprofen. They could take muscle relaxants or corticosteroids. For the neuropain, like the sciatica and stuff, what is most helpful are anticonvulsants or anti-epileptics, all right, rather than opiates. Opiates will not work on neuropain, so we want to go with the anticonvulsants. They may have steroid injections at the side, and that's done under conscious sedation and fluoroscopy. Or they may have major surgery, the removal of the disc. It may be a discectomy or a laminectomy. A laminectomy, of course, involves fusing or fusion of the spine, all right? So let's talk about a little bit on those cervical surgeries. Because of the area where it occurs, we need to make sure that we protect the airway. So we're going to monitor for any complications that may involve the airway. That would be to see how they're breathing. We're going to monitor for any swelling, bleeding, or drainage that may occur. We're going to apply an ice collar to help with the swelling and, of course, the pain medications. We want to assess if they're able to swallow, because all of this can be potentially affected by the swelling that will occur. The laminectomy, of course, we want to protect the spine. They will be wearing braces, and when they go home, they may wear the brace or may not wear the brace, but we want for them to have early ambulation. It is quite painful, all right, so pain management is a big component of it. They also will be on morphine PCA pump medications. The other thing is to remember that with any surgery that involves the spine, any spinal surgery, postoperatively, we need to inspect the dressing for any leakage of the cerebral spinal fluid. So that's one big component. That's a major complication that can occur, and we need to observe for this, and we need to inspect that dressing. All right, the next section on here is carpal tunnel. Oops, sorry. Carpal tunnel, which is compression of the median nerve at the wrist. And as you saw, I really don't have any questions on carpal tunnel, but you will have questions in your exam 5, so I decided to go ahead and cover it here. Carpal tunnel, this compression of the median nerve occurs from repetitive movement or awkward movement, of the wrist. The awkward movements involve such things as, we're working on our computer and we don't have it leveled where we're not putting that strain on the wrist. So that's awkward movement. All right. What does it look like? Well, we're going to have an individual that is going to be experiencing numbness, tingling, pain, weakness of the affected hand, the involved hand. So we do have 2 tests, and you can review that, the Phelan's test and the Tinel's test. The Phelan is the severe flexion of the wrist, and after about a minute or so, you start feeling that numbness and tingling. That would be a positive sign. The Tinel's involves tapping on the median nerve, and you will elicit that prickly, tingling pain that will shoot through the palms of the hand. Okay, so those are some of the tests that we do for carpal tunnel. How we treat it: wrist immobilizers go a long way. Wearing the wrist immobilizers, because the carpal tunnel is worsened with the flexing of the wrist, the bending of the wrist. So we want to prevent that. And that's what the immobilizers do. They keep the wrist aligned, so it prevents that added compression on the median nerve. Also, anti-inflammatories such as NSAIDs, corticosteroid injections at the site, and of course surgery would be an option to release the pressure, the median nerve compression. If they have surgery, it's relatively simple nowadays. It's less invasive than it used to be. They do it laparoscopically. It's a 2-week recovery. Remember that with any surgery that involves nerves or blood vessels, we need to do neurovascular checks post-operatively, all right? So review in your head what you're checking for when you're doing neurovascular checks. We also need to teach the patient when they go home, because they go home right away, to monitor for any complications. And the complications, again, it's just like we're doing neurovascular checks. They're going to continue doing neurovascular checks at home. And we want them to immediately report if there is return of increased pain, tingling, or numbness, all right? Because that should not be present since we relieved the compression on the nerve. Okay, the other section in here is gout. Gout are the uric acid crystals, or the urate crystals that are deposited in the joint. They can also be deposited in this under the skin, in the skin itself, and of course they can also cause the formation of kidney stones, uric acid stones. So what is it going to look like, the gout itself? Person is going to have painful, inflamed joints. What joints are usually involved? It's usually your toes, and in particular, the big toe. All right, so that's what it looks like. We say, oh, they have a gouty toe. All right, and that's a inflamed and large, painful toe. All right, so how do we treat it? Well, we are going to, of course, treat the pain. Again, NSAIDs play a big role. Colchicine is also a medication that is used to decrease pain with gout. And then we have allopurinol, where we are going to promote the excretion of the uric acid. Make sure that if the patient is taking allopurinol, that the person is drinking lots of water. And that's so that we can prevent the formation of uric acid stones, kidney stones, all right? So lots of water, take it with lots of water. The other thing is that we prescribe them a low purine diet, which means limit the red meats, crustaceans, red wine, beer, sausage, cheeses, and increase the intake of fruits. Okay, the last section on here is about fractures, and as I said, I'm not covering fractures because you have that in your BN program, but we are going to look at complications that can occur with fractures. The first one, and being a very common one, would be skin breakdown under the cast, all right? And so you have a casted fracture, and oftentimes, it gets itchy and sweaty and stuff in there, so individuals have a tendency to do some scratching and be very creative as to the implements that they design, the popular one being the hanger. All right, so the signs and symptoms of skin breakdown would be burning or pain. Now, you'll have that if you had a fracture that involves some scrapes, skin scrapes. So the skin breakdown will feel like if you scraped your skin, so burning and pain. We need to report that because it puts the individual at risk for infection. Then, of course, the other one that we have here is infection. That would be infection of the site, the skin. And so what would be the signs and symptoms of infection? It would be warmth at the area where the infection is occurring. So the patient may complain of a warm spot somewhere along the casted arm or leg, whatever the casted bone, okay? Pain would be another one, and of course there may be a smell. There will be a discharge if there was an open wound to start off with. Again, reportable, needs to be treated with antibiotics. Osteomyelitis then is bone infection, all right? With the osteomyelitis, just keep in mind that there doesn't have to be an open wound, all right? It can be a closed fracture. So it's a bone infection that occurs. Usually it's a staph infection. And so what are the signs and symptoms that we're going to see? We're going to see constant pain that increases with movement. Now remember, when we cast a fracture, there should be relief of pain, all right? So if you have increased or constant pain that increases with movement, that should not be occurring with a casted fracture, okay? The other thing would be a fever that is greater than 101. We're going to see, of course, increased WBCs and swelling. Again, reportable immediately to the doctor. We need to start treating that bone infection. Is not a good thing at all. Compartment syndrome is the other one here. Compartment syndrome results because there is increased pressure in the compartment, all right? We have several compartments. Compartments is what we call, and of course it's a compartment where we have the tissue, of course, and then we have the nerves and we have the capillaries in there, the blood supply and stuff, all right? So compartment syndrome, there is increased pressure. The person may experience what we call the 5 Ps. The first one, the initial signs and symptoms that they will experience will be signs that there's compression of the nerve, the paresthesias, the numbness and tingling sensation that they feel. All right. Other signs and symptoms of compartment syndrome would be, of course, increased pain. Their pulse will become weakened. It may be thready. Their color will change to pallor, and it may even result in paralysis, all right? So those are the 5 Ps that we monitor for. The pain with the compartment syndrome is severe pain that is usually unrelieved by opiates, all right? So if you have somebody with a casted fracture, let's say a casted arm, you do not expect them to have pain so severe that an opiate is not going to control that pain. Again, reportable right away because we need to relieve that pressure. With a compartment syndrome and a casted arm, remember that cast serves as it provides a compartment that is not expandable. All right, so the pressure increases much more rapidly, and we need to take actions to relieve that pressure by cutting the cast. Fat embolism is your very last complication here. This is a long bone fracture complication. It occurs with fractures of such things as the femur, long bone. So what we have is that the person throws a fat embolus. And so we have an obstruction of the pulmonary vascular bed by fat globules from this long bone fracture. What do we see? What do we see in a patient that throws a fat embolus? The very first sign that we're going to see, we're looking for, remember, because it's in the lung, so it's going to alter gas exchange. So if I don't have enough oxygen that's being, it's being taken up or absorbed into the vascular system because, I have all this fat globules interfering with it, then my first sign will be altered mental status, all right? Altered mental status. Other signs that you could have with a fat embolism would be, of course, just like you have with a pulmonary embolism, tachypnea, tachycardia, dyspnea, chest pain. With a fat embolus, though, you also will have a patient that will have a temperature elevation, may have mild thrombocytopenia, and actually the appearance of petechiae. Usually the petechiae appears on the chest. All right. Again, we need to report a fat embolism right away to the doctor. Okay, so that's it on Unit 11. Those are the topics. Some of the information that I gave you, really you don't, it's not going to be tested in exam 4, but it may be tested in exam 5, all right? And as usual, if you have any questions, please send me an email with your questions and I'll go ahead and respond with clarification.